Okay, work me through this here. Tell me how you got pancreas here.
Um, so I think it was more of uh, probably a buzzword. I obviously I was between pancreas and spleen. So let me see.
Okay.
Let me just reread this one. I haven't broken down this. I kind of like I knew this question would take more kind of time to go back and see their explanation, so I kind of moved on from it. But it said after a sudden onset of tearing chest pain that radiates to the back. Uh, he smokes cigarettes, high blood pressure, and then they showed the images of the chest and abdomen, confirmed thoraco-abdominal dissection of the aorta, the areas and the compressed, which is the following. So I think my train of thought was I saw chest pain that radiates to the back. I feel like that's kind of a buzzword that it kind of keys you in on pancreas, and with its location and the image on the left, I saw liver, spleen, and kind of. I guess you don't really see pancreas that
Yeah,
much,
yeah,
but I mean, obviously, my MRI radiology uh, imaging technique. I mean, like my exposure to them isn't as heavy as a medical student, but
yeah. No, and that's
I
okay. No, I definitely for sure. I get where you're kind of going with. Actually, these two answer choices are not bad to get into. So I'm gonna say that I like where you're going with the clinical aspect, right? Because yeah, I mean, but I guess my caveat is what also gives you, chest pain that radiates to your back, aortic dissection, right? You know what I'm trying to say?
confirmed the dissection of the aorta. Okay, yeah.
So when you have an
And
aortic dissection, go
I
ahead.
will say the other concept I was thinking of is obviously the thoraco-abdominal dissection of aorta. And like if there was like some abdominal aorta dissection and maybe like SMA or IMA could have been involved and like kind of related to that path, but I couldn't think of like that concept. Like,
Sure.
like I know SMA, I start kind of thinking of like the third part of the duodenum, and then SMA, I think of Nutcracker syndrome, and then IMA, I think is like an L3. I don't really
Yeah.
know, what else would be affected by it, but then they showed that location in the image on the left where it's like right up in front of it. So in my mind, I'm like, maybe that is like an artery coming off of it. Or I guess like you said, it's probably might be the. I thought it was interesting in the image on the left how there's like a line kind of through that. Yeah,
Yeah.
that thing. And so I don't know if that kind of maybe was from the dissection of it,
Yeah.
but
Yeah.
I was kind of thinking of all that stuff, but I couldn't pinpoint it to a concept that I felt comfortable with. So I just stuck with what I knew about what radiates to the back, picked pancreas, and just didn't overthink it.
Sure.
But
Sure.
that's just
That's
because
okay.
I
Yeah. 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 No, definitely for sure. I'm okay with kind of how you're thinking. Okay. This is how I would have worked through this, right? So, they give you the diagnosis, right? It's an abdominal dissection of the aorta, right? And if you take a look at the MRI, right there, like you said, there's a line. I always say when you look at images, try to look at the most obvious thing, and there's a line through the aorta, which they already gave you this aorta dissection. And then you try to look, they're asking you, okay, so occlusion of this vessel would most likely compromise. So it's a abdominal branch off the aorta. Okay. And I'm gonna be with you here, Tris, and say like, I'm not great with my, thoracic abdominal, right? Thoraco-abdominal aorta, right? I mean, when's the last time I remember that? I don't remember a lot of it. But if you look at kind of this MRI scan, right? Um, you take a look at here, right? Actually, I think this might be, no, this is a CT scan, actually. I'm pretty sure, right? Yeah, it's a CT scan. Okay, so the reason why I know CT scan is the bone is highlighted. But anyway, so you have your liver, right? You have your liver here. Okay. What is this right here? Do you know?
Um, no.
So this could be your duodenum, part of your intestines, right? Because it has a lumen in
Okay.
the middle. Okay. And then what is this right here?
That's your spleen, right?
Yeah, that's your spleen. Okay. So keeping it simple, right? Because this is a sagittal cut, meaning you're looking from the side. I mean, you can use that if you want. But in my mind, right, you know that they're going to point to an arterial level or a branch coming off the abdominal aorta on this, on this screen or this level. So you're already thinking, okay, so you should be thinking, all right, is it the liver, the spleen, the duodenum? And so if you look at here, right, you're probably your best answer here is going to be your spleen because it's on this level. There's no liver, right? And I always say, when they're testing these images, they just want you to see the big picture. You get what I'm saying? They're not going to ask you what's this. They're not going to ask you, this, right? They're only trying to get you to look at the big picture things. So
Yeah. I guess if they wanted pancreas, they put it maybe would have drawn it in.
yeah, exactly.
Maybe.
Exactly. They'll put it in a little bit lower and things like that. All right, let's go to the next one here. All right, this one. Talk me through this one. Let me see. Is there anything I can help you with? I'm trying to think. Some of these is just you know or you don't, which this looks like a biochem question.
Let's see, hepatocytes are involved in including urea cycle. So let's see, why is it talking about urea here? See, the hepatocytes is found that cells dedifferentiate, they lose their functions, colcontrain compared to oh, so essentially all okay. I okay, essentially what it's saying is like if you don't have a liver working, what's gonna be like build
Yep,
up or what's gonna be more of.
exactly. Yeah.
I
So it's
think
gonna
if
be
I think at first my mind was thinking of like you couldn't do gluconeogenesis, so I was trying to find some kind of carb related thing, but I guess I didn't think of the bigger picture of anything that built up in the liver. So
yeah,
anyway,
exactly. You want to kind of be thinking to yourself, oh, okay, like just break it down into, oh, okay, so if the liver isn't working, right, aka like liver cirrhosis is a good example, right? You have increased BUN, right, which is urea, right? And so you can get, hepatic encephalopathy, you can get asterixis. So E is going to be your best answer here for sure. All right, this one here.
I mean, essentially the you're supposed to key in on. I mean, maybe this is something you've seen. Laryngoscopy shows multiple slender finger-like excrescences on both vocal cords. I honestly haven't really. I mean, I'd have to read the explanation. I haven't really. When I read this, I hadn't really covered anything that covered the vocal cords. Like when you learn HSV 1 and 2, you think of like oral, mouth, um, versus like genitals. And then when I think of HPV, I always thought of like, maybe bumps or some kind of nodules of the mouth or like nodule kind of based things that, could lead to cancer, like in genital area, but never really have heard of it in like this before.
Sure. So let's talk about this, right? Obviously this is in my field as an ears, nose, and throat doctor, but yeah, for sure. So the reason why HPV, remember, what does HPV like to invade? What kind of cells do you know?
Squamous, I'm
Yeah,
gonna guess.
squame, right? Like epithelial cells, squame, right? Your
Yeah.
vocal cords at the very tip of them, right? The histological layer is actually squame. So
Mm.
so it can
Yeah.
invade and create papillomas, right? So it's called respiratory papillomatosis, right? So little grape-like things on your vocal cords, and that can happen because of vertical transmission, right? So from mom to baby, right? If she has HPV around her vaginal canal while baby's coming out, can spread to kiddo. So it doesn't turn to cancer, right? Most don't, right? Very rare of malignant transformation because it's the low risk strain that caused the papillomatosis or the wart-like things on your vocal cords. So subtype 6 and 11, and then of course 16, 18, 31, 33. Those are the ones of like cervical cancer or oral pharyngeal cancer. So know also that HPV can cause you tonsillar cancer or base of tongue cancer. So, and we see that often, very often also.
When it causes the tonsillar cancer and stuff, I guess that would be the, I don't know if you know this or not, but the would it be more the, I guess the higher strain, the
Yeah,
16,
yeah,
18,
16, 18,
31.
31, and 33. Exactly the same that causes you cervical cancer.
Okay. Okay.
Yeah,
I think the bigger thing is like instead of being like, oh, I've never heard of it with vocal cord, if you knew it was squamous, like if it was something related to squamous, I probably would have jumped on that. But you have to break down, I guess, knowing that the vocal cord has that squamous layer.
for sure, for sure. And this is, a tougher question for sure. I know, during your first 2 years, they don't talk too much about this, but yeah, just know that, they like asking, HPV because it can affect multiple areas of the body, right? The cervix, right? Can affect, vaginal canal, right? Can affect, oral pharynx, right? Can affect, your larynx, right? So all these things, right? And of course your skin too, right? Like you can get warts from HPV too. So yeah.
Gotcha. This was weird. I don't even know really how to explain it unless I just read the question or uh, basically it says ischemic heart disease because of increasingly severe chest pain, uh, blockage of LAD, and then you use palataxel. And I think of palataxel, I think of like, microtubule, spindle kind of related thing. And it says, what's like the mechanism of action? And then it says prevention of smooth muscle growth over the stent. So when I was looking at this, I was thinking of some answer choice related to kind of some cytoskeletal microtubule kind of some kind of structural thing. And so when it includes smooth muscle growth, I didn't really understand that. But I guess in the answer choice, they probably say something or in the rationale.
Yeah, yeah. This is a drug eluting stent, right? This is I don't know why they ask this every so now and then. I haven't seen this question very often. Maybe one time, like I know exactly where another question that's similar to this is a very, very old UWorld question, just one of them. But yeah, just know that these stints, okay, these drug eluting stents are to prevent kind of muscle growth over the stent or fibroblast formation. Okay, and so think of it like this, right? So you have a stent, correct? You have a stent inside an artery, right? And usually it is containing some drugs in there, and those drugs are to prevent your body from, you know, having fibroblasts grow on and over it, because if that grows, then it will occlude the stent again. And so that's what really the drug is for. It's a what is it called?
When you drew that image, you said the fibroblast to grow, but what was its relation to smooth muscle that you
Yeah, so
saw?
it brings in smooth muscle, right? It attracts smooth muscle to grow into it. It's kind of like
Okay.
it's like the intima of the artery. So, let's draw a 3D structure here. So here's your stent, right? So the stent is within another tube, which is your artery, correct? And so if you imagine, right, this stent is laced with drug, which is, paclitaxel, right? So what ends up happening is if you didn't have a drug eluting stent, your body would start to ingrow into the stent itself to kind of how do I say this? To kind of ingrain it. Does that make sense? Because it is trying to, in a sense, it's a foreign object, right? So your body is trying to either one cause granulomas and get rid of it, or two kind of bury it and kind of, because that's not the natural surface of inside your artery, right? And so
Right.
the smooth muscle, quote unquote, right? When you have in your arterial system, you have smooth muscle, right? And so when you get inflammation, smooth muscle growth, etc., right, that will eventually occlude your stent, causing you to have the same issue, right? Meaning you're probably going to get another heart attack, right? So you don't want that.
Right.
And so they put in, anti-inflammatory drugs and things like that inside the stent to prevent this from happening. So to keep it as
Gotcha.
open as possible for a long period of time. So
So it's almost like when you give it, you prevent the fibroblast growth, which will help prevent smooth muscle from growing over it. Is that what you're
yep,
saying?
yep.
Okay. Um, okay. So essentially, physician, woman goes 28. She has headaches. Um, and then her mother and aunt have hypertension that were diagnosed at young ages, and then patient's blood pressure is 220 over 110. Abdominal examination shows a periumbilical bruit. Uh, Angiography is most likely to show which of the following. So I think bigger picture here is anytime they love hypertension questions. And I guess if you have a young female,
Bingo.
and I think young female, and then also too like family history of both women at young ages
Yeah.
being diagnosed with it. I think when I read this in the flow and the moment of it, when I read periumbilical bruit, my and then like so, like an abdominal thing was found, I was kind of thinking of hypertension related to kind of like not esophageal varices, but that caput medusa kind of thing, or like something similar to that being done. So I was thinking some kind of abdominal related thing in the
So
moment.
talk to
So
me, since you said kaput medusa, what population do you usually see that in? Like,
alcoholics.
yeah, alcoholics, right? Liver cirrhosis, right? Is there anything in the question to make you think something like that? You know what I'm trying to say? Big picture wise.
Right, right, right. No, it's like if you think about that fact and like follow it back, technically there'd be kind of some liver
Yeah.
or edema or something related to that involved in the question.
So my thing with this, right, is you got to relate everything to each other, right? You can't say abdominal examination shows periumbilical bruit and isolate that finding, right? It has to fit.
Right.
Your whole picture has to fit with everyone else, right? 28-year-old family history, also of young people with high blood pressure, uncontrolled, right? Severe headaches. And what is a periumbilical bruit? So talk to me. What does that even mean? You know what I'm trying to say? Like what is a bruit?
Yeah. Like usually I know like you have carotid upstroke bruits, which I think is normal. Um, so I assume a bruit is some kind of like upbeat and like arterial blood supply, like abdominally, that's probably like not supposed to be there, but it
Yes.
is because of
So
hypertension.
a bruit, I'm gonna just tell you, a bruit is just a fancy term, right? That means turbulent flow, and you can hear it. So if you have an obstruction or something like that, and remember, blood flows is supposed to be laminar, but if there is some turbulence, it's gonna whirl around here, right? Right. And when it whirls, you can hear that on physical examination. Because if you think about the way I always explain bruits and murmurs and things like that, right? When you rush something past something narrow, it's going to cause turbulent flow and it's going to vibrate and cause a sound, right? And my analogy to make it very simple to you is, can you whistle with your mouth completely open? No, right? Unless you have
No.
lungs like a truck, right? But impossible, right? You need to blow out air through a small hole to vibrate to cause a whistling sound. It's the same way with blood flow, murmurs, things like that. So if there's a stenotic segment where blood is flowing through, it's going to make a sound. So when they tell you a periumbilical bruit, periumbilical meaning around the belly button or umbilical area, right? And you hear a bruit, meaning that there is some kind of arterial turbulence around this area. So if you take a look at, here's the belly button, let's say around here, there's a bruit, right? So in your mind, you know that some artery in the abdominal cavity has turbulence, which then fits, obviously the renal arteries are, down in the abdomen, right? That makes sense.
Right. Yeah, I think yeah, so understanding like a brewery is not normal. It's a it's a it's because of turbulent blood flow.
Yep.
Um, and understanding that. Uh, so carotid upstrokes, is that normal?
I mean, you shouldn't hear carotid bruits, right? Like,
Breweries, yeah.
yeah, carotid bruits are usually caused by carotid stenosis, right? Either that or some kind of aneurysm, right? Because an aneurysm can also cause turbulent flow, right? So if you have your carotid, artery and you have a little outpouching, so as blood flows this way, some of it's going to come in and whoosh out, right? And that's going to cause turbulent flow. Or if you have carotid stenosis with atherosclerosis, right? So if you have atherosclerotic changes of your artery as it flows through here, it's going to vibrate, right? Because of turbulent flow. So yeah, not normal, right? Me and you should not have carotid bruits or anything like that for the most part. So
Yeah. I like what you said, the bigger picture here, relating everything. Like obviously like seeing that one fact, but playing it back and seeing if it, one, what is my idea of Caput Medusa revert into, and does it fit the rest of what is being talked about here? So
exactly.
I
Big
think
picture.
that's huge. I think that's huge on this test. And then
Yep.
step one, like what they're kind of shifting to.
Yep. Like I said, in isolation, right? This could mean anything, right? If you don't look at the rest of the question, this could mean, like you said, it would fit your answer, right? Because this would an aneurysm of the abdominal aorta will cause an umbilical bruit. 100% that's going to cause it, right? But remember, aneurysm dilation of the abdominal aorta, usually older people, right? Like triple A's, right? Smokers, men 60, 70, right, years old, right? So that this whole picture of A is completely opposite of what's going on, you know? So
Yeah. And in general, would you just to understand this concept, uh, say that when you talk about smoking, so this smoking relate more to atherosclerosis than like kind of fatty stuff than like obesity, or like I've realized I've seen like smoking as more of a risk factor
yeah.
for
So
than like obese, and I think it's for atherosclerosis, right?
yeah, because remember, smoking causes a bunch of vessel inflammation. And so when you have vessel inflammation, it's going to want to clot and fibroblast, inflammation, fibrovascular core, things like that, right? Like plaques and stuff
Yeah,
like that will like to build because I mean, this is going to bring it way back to some of the vascular physiology, but so smoking causes like vasculitis, right? Like vascular inflammation. So remember, you have your endothelium, right? Imagine smoking causes some damage to the endothelium, and then your body is going to what? Your body's gonna heal that, right? The basement layer of the endothelium is going to try to recover it, right? And then you have, a little clot formation to then kind of bridge this area, and then smooth muscle forms. And over time, systemically, if you keep smoking, then you have all these vessel damage changes, et cetera. And so you keep getting this proliferation, right? This chronic proliferation, right? And that vascular insult or injury is going to continue to cause you to increase risk of atherosclerosis. And then eventually you're going to, it's a chronic thing, right? It's usually not an acute thing. It's a very, very chronic thing, right? So, actually this headways to another concept too. What's worse when you're dealing with vascular issues, an acute blockage or a chronic blockage? And tell me why.
say the question one more time.
What's worse, like clinically, an acute blockage of an artery or a chronic blockage, like over time? And tell me why, if that makes sense.
I assume chronic because I think when I think of chronic inflammation, I think of more like fibrotic or collagen kind of deposition, maybe. I
Sure.
don't know.
So actually, the question I'm trying to get you to think about is, so let's say I have blood flow, right? Let's say this lumen of this artery is completely normal, right? And then over time, you just slowly, over years, you slowly get occluded, right? So now I'm 50% occluded, right? And then over years and years and years, now I'm 70% occluded. Is that
Right.
worse, or is it worse when you get 100% occlusion in a short amount of time?
I'm probably 100% occlusion in a short
Yeah,
amount of
this is
time.
worse, right? And that's what causes a myocardial infarction. So coronary
Right.
artery disease is a slow chronic process of this, right? And the reason why it's not that bad, even there's some people that don't have many symptoms, even when you have like 90% blockage, and you might be like, how is that possible, right? You're not getting that much blood flow. It's because if you do it over time, then your body will create new, they call it collateral circulation to where it needs to go,
Right.
right? But if you have an acute, right, like AKA like a MI, myocardial infarction, AKA like a, you know, a little a little injury to the endothelium that breaks off, like a plaque that breaks off, and then your body overreacts to create a clot, and you completely clot the artery. You cut off that blood supply immediately to the heart, and the heart dies because there's no collateral. You get what I'm saying?
Yeah, yeah.
So acute changes in blood vessel or blood supply is way worse than chronic issues like coronary artery disease and things like that.
Okay.
Okay, this one here.
Um, Let me see. So essentially, there's a boy, fever, headache, nausea, antibiotics, lumbar puncture is done. Photograph of gram stain. The fluid is shown. During the next 1 hours, he develops bleeding in the gums from all IV puncture sites. He is intubated for respiratory failure. Given so when I read this, I think I saw Neisseria. Like again, that picture reminds me of Neisseria. I don't know if it was meningitis or gonorrhea.
Okay. So
But you
Tristan,
you have
so I was gonna just so I can interject here. So you asked, okay, so you saw that it's Neisseria, and you asked, is it meningitis or is it
gonorrhea, but
gonorrhea, right?
but meningitis probably because the lumbar puncture, right?
Well, it's not just that, right? How often do you see gonorrhea in a 6-year-old boy? I
Yeah,
know,
that's what.
right?
Well, is that past though? Uh, I guess can't that be given to the offspring?
Yeah, not when you're immediately born. This kid's 6 years old, right?
Right, right,
Right. So I'm trying to get you to realize things clinically, right, Tristan? So
right,
you on your test, you're like, oh, is this gonorrhea or Neisseria meningitis, right? But right, like gonorrhea is a sexually transmitted disease, right? So how often
right,
are you gonna give a 6-year-old boy on a test, or even in real life, how often are you gonna see a 6-year-old boy unless obviously child abuse, rape, or something like that, right? They're not gonna give this kid gonorrhea. You understand what I'm trying to say?
Yeah, yeah. That makes sense. Seeing it clinically to verify.
Yep. So you got to ask yourself, okay, does this make sense clinically, right? Can I see gonorrhea in a kid just by based off age? The answer is probably no. Also, on top of that, right, gonorrhea doesn't give you, right, doesn't give you headache, doesn't give you, right, doesn't give you headache or meningitis like symptoms, right? It should be the way gonorrhea is presented, even on a, on a symptomatic standpoint, right? Penile discharge or vaginal discharge, right? They say nothing of that here. So.
Right. So, yeah, I see what you're saying. Because I think at first, again, reading it first pass through, my mind shifted to that, like a factual thing versus, I guess, technically clinically how you could reason through determining a point. So yeah, that makes sense with the fever or the headache and the lumbar. And then the other thing I saw was the bleeding gums and bleeding from gums and IV puncture. When I think of that, I thought of DIC.
Yeah, exactly.
Um,
So
and
that's
so
right.
I was trying to I was trying to relate. I think on the test again, I saw DIC and then like thought of pulmonary embolism, which was the choice I picked. But relating the two, I haven't read their answer rationale for this one, um, but I'm trying to think of their relationship right
So
now.
let's talk about this on a clinical standpoint, so you can get who gets pulmonary embolism since that's what you picked. Like, give me the patient population that you usually are the risk factors for pulmonary embolism.
Older
Yeah,
people.
usually older people, right? Long travels, like they sit in a plane or a car ride for hours, right? So their blood is not flowing as well, right? And then they form a clot, right? So, Tristan, it seems like you know these things, right? But like I said, I'm trying to get you away from the buzzwords, right? You're like
Right. It's
DIC.
like the
Oh,
way you're
okay.
connecting it.
Yeah. So yeah, can pulmonary embolism or trauma cause DIC? 100%, but it doesn't fit in this picture here, right? So you got to ask yourself, okay, so what kind of infection can cause DIC? And if you remember Neisseria meningitis, right, that can cause that Waterhouse-Fridson syndrome where it kills your adrenal gland. That can cause DIC.
Oh my gosh. Yeah, I remember the sketch. I So water, right? That's adrenal. Like I knew it was like the water tower and sketchy, but that's adrenal. I because like that
Yep, that's
sketch.
adrenal hemorrhage. Yeah, so you destroy your adrenal glands, the DIC goes crazy, right? So that's what I'm saying. I want you to connect things clinically, right? Because like I
Right.
said, I'll give you an example, right? Can pulmonary embolism cause DIC? 100%. Can toxic epidermal necrolysis cause DIC? 100%. But remember, this kid has Neisseria meningitis, right? So what is associated also with Neisseria meningitis besides DIC? Oh, okay, adrenal hemorrhage, which is part of that disease process if you get very, very sick. But the rest of it, not really. You know what I'm trying to say?
Yeah, that's an interesting like how you think about it. But yeah, like how you're yeah, like how you can take that like the patient age and uh who is affected by pulmonary embolism and things like that.
Yeah, but
So
it's what I'm trying to get you to think that way because you might be like, man, like that's tough to do, etc. But you already like when I ask you these questions, you've answered all of them right? You're like, oh, what does a pulmonary embolism person look like? Oh, you told me older person, right? Someone who sits for a long time. So you've learned these things. So I'm trying to tell you, use everything in your toolbox, right? They're not going to make you pick an answer that doesn't fit clinically, right? Like this test is supposed to, like, I see as a 6-year-old boy that's coming in, right? If you treat it as a patient, then it'll make a lot more sense because does a 6-year-old boy patient usually get congestive heart failure? Unlikely. Does a 6-year-old boy usually get pulmonary embolism? Unlikely, right? Toxic epidermal necrolysis, meaning that the skin is sloughing off. Well, there's only X amount of things that can cause that, right? Like, Steven Johnson syndrome kind of ordeal, right? So usually drugs, they don't
mm,
say that he's in any drugs, right? So maybe some empiric antibiotics, so maybe, right? But then you have to connect, right? 6-year-old boy, what kind of, he has like meningitis like symptoms, so probably Neisseria meningitis. What does that relate to? you know what is Neisseria meningitis, right? What is it associated with? Okay, so only thing that fits with DIC in this is adrenal hemorrhage. So
yeah, that makes sense.
all right, this one here.
So as a starting point, and I don't know if I like psyched myself out on this, but I always like mix these questions related to like anaphylactic shock or like allergies and
Okay.
IgE relationship to eosinophil versus histamine and mast cells. So obviously this I know what a hype and this all fits in the hypersensitivity like type 1
Okay.
reaction.
Mm-hmm.
Uh it's like some of these factors. I don't know that it's related. I don't know if that's the same thing as anaphylactic shock or not. But point is in this question, let's see. So you have a 27-year-old woman. She comes into the hospital, lower abdominal pain, 1 week history of lower abdominal that became more severe 2 days ago. She has fever, nausea, vomiting. She is a high temp, high pulse, pressure's okay, tenderness in the left lower quadrant, light palpation and percussion, and then a CT scan of the abdomen of oral intravenous contents obtained. Shortly after, she has audible wheezing and lung fields, and the rash shown in the photograph. Her pulse is now this, blood pressure is this, which is volume mechanism is a skin reaction. So, and first of all, in my mind, I'm thinking she had when she went in for like the issue, like there's some kind of drug or something that was given where she had an adverse reaction. So I'm thinking like some kind of allergic reaction possibly. And then also with the image. Um, so I
Yeah,
know mast cells
yeah.
release histamine, but I get confused because I remember reading somewhere where oh, like the major player is eosinophils, and so I get confused
Yeah.
when to put eosinophil IgE and when to put mast cell.
Yeah, sure, sure. I mean, I think if you get it between those two, then it's great. The way I always explain it is like eosinophils is like that internal inflammation, right? Like, there's only a couple things that cause eosinophils, right? Allergies is one of them, right? What is the other thing? Do you remember? Like
What was your
IgE.
question?
What kind of creates a response with eosinophils or IgE besides allergy? There's other things too, right? Do you know what other things can cause it?
Parasites.
Yeah,
Is that what you're trying
parasites,
to?
right? Parasite infection, things like that, right? But that's usually
Yeah.
like a blood kind of ordeal, right? But when you're talking about symptomatic swelling and things like that, you're in like skin rashes, swelling, urticaria, things like that. That's dealing with the histamine that's released from mast cells, if that makes sense to you. So if
what
you,
was the last thing you said about urticaria?
yeah, so all those things are by histamine release, right? Because it's just caused swelling. Histamine causes a lot of swelling, right? Which is the bad thing about anaphylactic shock is you swell. Even your airway swells, meaning you have an issue breathing, right? That's why it's so dangerous, right? But if you look at kind of, your IgE, right? And from your eosinophils, they release the IgE to attach to the mast cells to release that, right? So the better answer when you're dealing with anaphylactics, urticaria, even what is it called? Even if you get stung by a bee, you have some local swelling, right? That's from your mast cells, from the
So
histamine release from the mast cells.
you're saying that IgE binds the eosinophils, and then eosinophils release mast cells, which release histamine. So the more direct answer that causes symptoms is histamine.
Yeah, so when you deal with class, like the IgE attaches to the mast cells. I'm just making sure you get that right. IgE
Uh,
attaches to the mast cells, which then the mast cells are triggered to release histamine.
IgE touches the mast cells. So eosinophils? What's the relation between eosinophils and IgE?
Yeah, so IG,
I know IgE releases or attaches to mast cells, but what
yeah, I
happens right
think
before that?
IgE, like it is released by eosinophils or versus, right? I think I'm trying to remember. IgE also helps like this whole process of, I want to say, does it help recruit eosinophils or does eosinophils just release the IgE? Let me take a look. Eosinophils and IgE relationship. Let's look. Because I know they go hand in hand, but I'm not sure. Um, let's see. Let's see. Let's see. Yeah, I think it's a little bit different. IgE is usually released from like, your class switching from your what is it, memory plasma cells, right? They create those antibodies. I think they play part of it where they're like a chemotaxin for eosinophils. But they are other things like your ILs, hey, which don't ask me which IL, I always forget. I think it's IL 4 and 5 or something like that, that attracts
Yeah,
the
yeah.
eosinophils too. But just remember, I'm trying to make it simple and short because if you go down the immunology route, I mean, even for my boards, I have to review every year because we get asked on allergy a lot. But keep it simple, right? All the symptoms usually that you happen for anaphylactic shock, allergies, things like that, is usually for the most part, like skin wise, swelling, things like that, is caused by mast cells releasing histamine. When you talk about eosinophils, that's more of like a systemic blood thing that's happening, is causing you inflammation, right? And different changes inside your body. But if you're talking about skin, swelling, airway swelling, that's usually like a bunch of histamine, which is not
Gotcha,
directly related to eosinophils. Indirectly, but not
gotcha,
directly.
gotcha. So IgE is more of a blood issue, and that's where you think of like IL 4 5
Yep, for
causing
your
IgE.
eosinophils. Yep, exactly.
And then and then from there is the IgE doing like its own blood effect, or like
It's
sep.
yeah, it's all intertwined.
Okay, but
Yeah,
I get the broader picture that you're saying.
yeah. I don't want to go too much into detail because it gets very complex because IgE will
Right.
interact in some ways, right? Like I said, IgE helps interact with mast cells, which release histamine. That's direct. But IgE also works with the other IL 4 or 5 to recruit eosinophils. Eosinophils will then cause a like inflammation inside the bloodstream, right? To then further on the allergy process, right? Which will then recruit even more mast cells. And it's like a complex web of how they all interact with each other. But lots of inflammation. Just we'll keep it simple like that.
Gotcha.
All right, let's go to this one here.
Okay, let me read the question. So, a 43-year-old woman comes to the physician because of a 2-month history of intermittent abdominal pain. The pain occurs after fatty meals and is localized to the right upper quadrant. Um, ultrasonography of the abdomen shows cholelithiasis. The patient elects to begin a trial of ursodiol therapy before considering operative treatment, which are the following primary mechanisms of action of this medication. So, as a starting thing, I had like the night before just reviewed like the different types of drugs, like, and so I felt like comfortable with it. But then when I read this question, I think I honed in more on urosodial, which is like I've never even heard of that before. So I was like, oh man, like I don't really know what this is. Um, versus kind of honing in on the sentence before about like what actions happening and then like deducing whatever actions happening and then thinking like physiologically what's going on.
Yeah,
So
yeah.
now that that's kind of more what you're supposed to do. Is either
Yep.
pain. So after, so I'm, and this is like a point where I probably need to review again, but cholelithiasis and that, and so I'm let me think because I always get that. That just means there's a stone in the gallbladder duct, right? Is it in the
Yeah.
gallbladder duct?
Yeah.
Well, because like it's after fatty meals, so that means you're trying to release bile, and there's probably a stone or something there that's causing the problem. So if it's a stone, if it's cholesterol, you want to probably, I guess, sometimes I get mixed up because there's some things that like you, I guess you would secrete cholesterol or something to like lower it or
Yeah, I
something like
mean,
that. Anyway,
yeah. So I always say just a test taking. Sometimes, this question is difficult in the sense that urosodial therapy, if you know what it is, then it becomes a very easy question, right? That's just the mechanism of action of it. But if you want to talk about a test taking strategy standpoint, I always say if you don't know like something part of the stem, then you can't use it. You get what I'm trying to say? Because
right,
if you try to use it, like for instance, you're like, oh my gosh, what is urosodial? What is urosodial? Well, you're not going to remember that piece of information right now, right? So you want to use everything else in your repertoire that they give you and try to pick the best answer possible.
right,
So
right,
if I was in your position, I'd be like, delete the patient elects to begin a trial of urosodium therapy before considering operate treatment. So this sentence right here in your mind doesn't exist, right? Because it's not helpful. You get what I'm saying? So that means the
right.
only thing you can use is 43-year-old woman, 2 month history of abdominal pain, fatty meals, and then she probably has, cholelithiasis, aka gallstones, right? Which are the primaries and mechanism of treatment of this, right? And then you can pick an answer from there. But this one's difficult because they're really asking you, do you know what the mechanism of urosodial is, which is going to be decreased cholesterol by secreting it into the or decreasing cholesterol secretion into bile, which prevents gallstones, right? Inhibition of 3-HML CoA, that's a statin drug, right?
Right. I think I saw cholesterol when with statin, like you're trying to reduce cholesterol or something.
Yeah, for sure. No, and statins are good drugs, but they're not going to help with gallstones for the most part, right? They're going to help with
Mm.
your overall cholesterol levels in your blood, like your LDL levels and things like that. So
They help with cholesterol. You say they don't help with stones. Is that what you
yeah,
said?
they usually don't help with stones. No, this is
Okay.
usually reduce intrahepatic cholesterol, right? There may be, it says evidence that they may be at lower risk, but it's not used for that purpose. Statin drugs are really wide used in today's primary care because they're good at lowering bad cholesterol in your body, but it's not used to prevent gallstones. That's not its
So
main
just
use.
as a general thing, so this one was decrease cholesterol secretion. Yeah. So because you have like high levels of, or because you have like some kind of stone, I assume it's some kind of cholesterol stone. Uh,
Most commonly, yeah.
you don't want to put more cholesterol in, like, because I
Yeah.
remember there's that one drug where basically, I think it's like they all start with chole, where essentially you secrete bile acid into the gut,
Yep.
and like secreting it in there, therefore shunts everything like from cholesterol to bile acids. So that way it's like helping. So I didn't know if like increased secretion or decreased secretion, if like that's,
Yeah.
if there's like, uh,
Yeah. So the
yeah, go
best
ahead.
way, I get what you're trying to say. So the best way to think about it is, so I think about it, this brings it back to chemistry, right? Your solution, and you can use the same theory for kidney stones too, or all stones in general. Solution versus solute. Do you remember those words?
Yeah, yeah.
Okay, perfect. So the solution in this situation is bile, right? The solute is like cholesterol. Okay. If you have more solute than solution, meaning that the solute will not be dissolved in the solution, so you're going to end up having gallstones, right? So one of two ways to prevent gallstones: increase the solution, meaning, you're dumping a bunch of bile, right? So that you have more to dissolve the cholesterol, or decrease the amount of solute, aka decrease the amount of cholesterol. So this drug by itself decreases the amount of cholesterol inside the bile, meaning that you have less
Mm,
cholesterol, meaning that it's going to be dissolved in the bile. You get what I'm saying? So you're not going to
yeah,
create stones. So that's going to be the same thing when you think about kidney stones, salivary duct stones, things like that. That deals with solution and solute. So same ordeal.
gotcha,
And
gotcha.
same thing with uric acid kidney stones, right? Which is why like you have allopurinol, which decreases the amount of uric acid, right? Things like that, right? It's the same thing.
Okay.